Hello everybody, this is the talk that I gave recently at the APCCC in Lugano, focusing on treatment monitoring of patients with metastatic castration-resistant prostate cancer. Here are my disclosures. So we need to keep the focus today on the metastatic castration-resistant state, and what I'll try to do is to show you the potential, prognostic potential of imaging. I'll demonstrate to you the limitations of conventional imaging for assessing response, particularly in people who have multiply treated bone disease. I will talk to you about the frequency and the clinical importance of discordance in the triple assessment response methods. I'll indicate to you that the current criteria, which rely on the lack of benefit, impairs the timely treatment switching in clinical practice, but I will acknowledge that we need higher quality level evidence on the role of next generation imaging technologies to assess the benefits of earlier treatment switching, which is the focus of this talk. Now, we know there are highly heterogeneous outcomes of men with the metastatic castration-resistant state from a few months to several years, and there are multiple prognostic determinants which are clinical, histopathological, blood work, liquid biopsies. But today I'd like to focus on the imaging aspects. So the organ of distribution is important, for example, whether the disease is lytic or sclerotic. The number or volume of disease is important, regardless of how you measure it. The relative volume of PSMA-avid versus FDG-avid disease and how well they match is important. And the time it takes from going from the non-metastatic castration-resistant state to the metastatic castration-resistant phase is also important, as is what your responses were to previous therapies. So this is data that shows that in the metastatic castration-resistant state, if you have predominantly bone disease, if you have predominantly nodal disease, you will have a better outcome than, for example, if you have liver metastases. And in this particular instance, you would survive worse. We know that the number of deposits is important. So this has been measured on this in this paper using whole body MRI. So few deposits, you live better than if you have many bone deposits. And this, of course, then transitions to a volume assessment. And again, you can see in this study where in a multivariate analysis, the volume of disease also predicts how well you will survive the metastatic castration-resistant state. And of course, that would apply to other technologies. In this particular instance, you can see PSMA-PET CT. And here what you see is that the baseline tumor volume segmented out on a PSMA-PET CT is again highly prognostic, but you'll notice how there's a gradation in the graph on the top right, where if you have smaller volumes of disease, you live longer, and if you have larger volumes of disease, you live shorter, as you might imagine. So what this means is that the tumor volume and the organ of distribution is highly prognostic, and that's because clonal evolution and resistant mechanisms seem to kick in more the greater is the volume and the anatomic diversity, which then implies that treatment switching to the next line of therapy is best done when the volumes are smaller. The question is, where is the disease and how much is the disease? So if we look at how patients transition from the hormone-sensitive state to the castration-resistant state, you'll notice that the number of lines of therapies that are still available in the castration-resistant state decreases over time because they're being used at an earlier time point. So second-line therapy, for example, in CRPC is if not previously used, which means there are very few individual options that are still available in the castration-resistant phase. So treatment switching, when progression occurs, remains problematic with the conventional methods of assessing response. And at the moment, we use the triple assessment method to look for disbenefit, not for response, but for disbenefit. And we rely on PSA progression radiographic progression and clinical progression. And our focus today, of course, is to talk about radiographic progression. Now, we know that both bone scans and CT scans don't give us timely readouts of progression. So bone scans, for example, assess the osteoblastic activity to the presence of cancer. So there has to be signaling. If there's no signaling, you won't see a bone scan readout. And therefore, you find that superscan patients, for example, are excluded from clinical trials, and we are often seeing examples of patients who are progressing clinically without bone scans changing, and I'll show you an example in a minute. Similarly, we have problems with the CT scans. You can't really see the fullest extent of the active disease within the bone marrow because, again, we're looking at the interaction of the osteoblasts with the tumor cells. And when you've had multiple prior treatments, your bone marrow is scarred to death, which means that you don't really, again, get an idea of what's alive and what's not alive. And so this state of clinical progression without radiographic progression is in fact really quite common. So here's a man. On the left, you can see that he has metastatic castration-resistant prostate cancer. He's on a clinical trial because there are very few options in men like this. And he's on an immunotherapy and a PARP inhibitor. And you'll see that on 3 separate occasions, we call this man stable in a prospective fashion, and we were blinded to the PSA, but he developed unequivocal clinical progression, at which point he was taken off the clinical trial, and we repeated the whole body MRI scan on the right-hand side. And what you notice is that PSA is clearly has probably increased, and when we repeated the whole body MRI scan at the end, which we weren't allowed to do in the middle, you can see he's clearly progressed. And this is a real issue for many patients. And this phenomenon of clinical progression without imaging progression is in fact really quite common. So unequivocal clinical progression, worsening of the clinical state, without seeing anything on a bone scan or CT scan, occurs in about 40% of patients in the castration-resistant state with CRPC. But the opposite also happens. Patients can stay well or apparently well, and you can see imaging progression, and that occurs in up to about 30% of patients with enzalutamide, again in the castration-resistant state. And this is really problematic. So these non-benefit criteria, which are often used in clinical trials, are less useful from a clinical, everyday clinical efficacy perspective, and also for early clinical trials where you're trying to get a readout of response, not necessarily progression. And this is a real issue. Now, it turns out that next generation imaging technologies are able to creep into this space, and the preliminary data is certainly showing the usefulness of next generation imaging at assessing therapy effectiveness, not non-effectiveness, in clinical practice and early phase clinical trials. So here's some data on the using the response assessment criteria for PSMA-PET CT. And if you look at the Kaplan-Meier curve on the bottom on the left-hand side, you can see that if you have a partial response using the criteria, you have a longer survival than if you have progressive disease, which is exactly what you'd expect. So these are giving us a positive readout rather than a negative readout. So whilst there are multiple challenges, what we can say now is that there's a great opportunity now for next generation technologies to inform on the treatment strategies on how to manage patients with the metastatic castration-resistant state, because it enables us to directly look at both the morphological as well as the functional activity of what is happening in bone in particular. So we can identify not only microscopic metastatic disease, but microscopic progressive disease. And it enables a more precise assessment of what's going on where. So the disease extent, any potential complications that may be occurring, and any responses. And it looks like the new data is beginning to show us that it might actually be predicting for survival also. So here's a man who has metastatic hormone sensitive as well as castration resistant prostate cancer, but this time just in the nodes. You'll see that in the hormone sensitive state in the top left, you can see that as the PSA begins to rise, so we can see an increase in tumor volume. Then the patient is obviously in castration resistant state and gets treated with abiraterone. And when he goes into the metastatic castration resistant state, you'll notice a number of interesting phenomena. So for example, you'll see how the bone disease appears. For example, at the thoracolumbar junction, you'll notice how lymph nodes in the retroperitoneum have responded really quite well, but the lymph nodes in the groins have progressed. So this is this discordant response occurring within the same organ system. And then you see growth occurring within the prostate gland itself. So you begin to see greater discordance within organs, but also between organs in the castration-resistant state. And this is depicted very well using imaging methods such as this. But you can in fact go much further. It's possible to look at viability habitats, particularly in the bone marrow. So you see here, I've colored everything in red as being viable, and everything in green as being dead, and yellow being tumor cells that are between alive and dead. And it's possible again to map these viability habitats in 3D. So you can say in this man with metastatic hormone sensitive disease, in this particular instance, we can say that in fact there are areas of clonal resistance within the marrow, for example, in the left femur and in the lower lumbar spine. These are the red areas that you see between the green areas. Now, with the whole body MRI technique, just like PSMA-PET CT, we have a system for codifying what we see, both based on the diffusion imaging as well as on the functional imaging. And we've also been able to define response assessment categories that tell us that progression is happening, if you wanted to use progression criteria. So progression highly likely, it's called RAC5, response assessment category 5, progression highly likely. And you can see how we have defined the criteria that indicates progression highly likely. And how good our radiologists are telling the differences between different response assessment categories. It turns out that the inter-observer agreement, even between a junior and a senior radiologist, is really quite good. And these are these darker colors that you see here. And you can see the kappas are between 0.6 and 1. And when you test this prospectively in head-to-head studies, comparing CT scans and bone scans with the new technology, which is whole body MRI, you can see how efficacious the MRI is. So, for example, in this prospective ongoing study being performed in Milan, we can see that response assessment category 5, progression highly likely, occurred in 25% of these 31 men as they were followed over time. And on the bottom right-hand side, what you can see is that when we knew that patients were progressing in the bone, you'll see how the bone scan is not showing you this at all in 82% of patients. And this is really very interesting. And this mirrors exactly what we saw in metastatic bone-only breast cancer. So again, we have the same problems occurring with breast cancer. And in this particular instance, when progression was occurring in the bone marrow, it was not shown by the bone scan in about half the patients. And here's just an example. So this man has metastatic castration-resistant prostate cancer, is being treated with cabazitaxel. He's clearly progressing on the whole body MRI. But if you look at the bone scan, nothing. No change. So this is again response assessment category 5, progression highly likely. Now, of course, it's important to remember that just because you can change management with using more sensitive techniques does not mean that patients will ultimately benefit from the change in the treatment. And this was actually shown by this study, again, looking at metastatic castration-resistant prostate cancer, but this time focusing on metastatic asymptomatic spinal cord compression. So when asymptomatic spinal cord compression was treated prophylactically and these patients were followed over time, you'll see there's actually no difference in the development of subsequent clinical spinal cord compression or of subsequent neurological deficits. So in other words, just because you change something and you can change a treatment does not mean that the patients will benefit in a prospective sense, and you need to do the experiment to show this. And of course, now we are beginning to see that with PSMA-PET CT in particular, that if you have responses, you're going to live longer. If you don't have responses, you will live shorter. So it looks like functional imaging will be able to help us in this regard. So what can we say about where we are in 2022? Well, in 2017, the APCCC said that for the castration-resistant prostate cancer state, you needed to perform imaging at baseline and before every new therapy, and then you had to perform it regularly because of the discordant responses that we were seeing previously. The role of next-generation imaging for response assessment is not yet clear, and I think we can agree with it. But what we can say is that if there looks like there's suspicion clinically, then it's worth repeating the whole body MRI scan or PSMA-PET CT to know what is going on. But the ASCO guidelines did say that if you had been diagnosed with polymetastatic disease, for example, with next-generation imaging, then you could continue to follow these patients using next-generation imaging to work out how you were responding and what your extent of progression was. So these are my final conclusions. Discordance between clinical and imaging assessments is incredibly common using bone scans and CT scans. And in fact, it's highly clinically impactful. So you need to be really careful about this. Vigilance is needed with regular and protocol-based triple assessments as a minimum standard. But beware that men will progress without your knowledge, but it may be that you have limited treatment options for these men. The survival and the impacts of next-generation imaging for treatment monitoring has not yet been shown completely. Remember that a good diagnostic biomarker or a good prognostic biomarker may in fact not be a good response biomarker. And in fact, prospective clinical trials using meaningful clinical endpoints still need to be done. Thank you very much for watching. I hope you found some of these remarks helpful for your clinical practice.